Hello and welcome to the Royal College of Pathologists Guideline Implementation Webinar Program. My name is Professor Sebastian Brandner and I'm the chair of the Working Group on Cancer Services. I'm delighted to be hosting this webinar today, where we have leading experts and authors of the dataset for histopathological reporting of anal cancer guidelines. They will be clarifying some aspects of the guideline that members may find difficult to implement in the form of practical tips and/or clinical scenarios. They will be here to answer all your questions. I'm pleased to introduce you to today's speakers and authors of the dataset for histopathological reporting of anal cancer guidelines, Dr. Moorghen. He is presenting the PowerPoint and the question and answer, and Dr. Wong, who is also there for question and answer. Before we really kick off, a few housekeeping items. Before we commence the webinar, I would like to inform you that the webinar presentation itself is approximately 10 minutes long, and then we have 25 minutes question and answer. So all the participants will be muted. So if you want to ask a question, please do so at our question and answer session, where you should submit your question in the Q&A function on the bottom of the control panel of your Zoom webinar screen. Now, without further ado, I would like to kick off by welcoming our speakers. Over to you.
Good afternoon to everyone, and thank you for attending this webinar. So I'm Moorghen. I'm a histopathologist, and I am aided and abetted today by my colleague and friend Wong, who is also a histopathologist in Bristol. So what I thought we would do would be to focus on those areas of the new guideline where there's been major changes as compared to the first edition. This edition came out in April 2024. We made a few changes and we'll focus on these today. And I'll start off first, and then I shall leave the end to Newton, who will then present you with a very short case, which illustrates some of the difficulties in relation to pre-cancer in the anal canal. And then we'll have the chance to answer some questions as they arise towards the end. So the main changes actually are on page 6, I believe, of the guideline, and they've been essentially copy-pasted on the screen here. They refer to the introduction of anal intraepithelial neoplasia, form of pre-cancer, which was not included before because we felt that it wasn't necessary because the dataset was a cancer dataset. But in response to feedback from many colleagues, we thought we would include AIN and SIL in the current version. So AIN and SIL is introduced. Then we also talk about P16, and then two other things also included in the guideline, but which will not formally form part of today's presentation, but may come up in the discussion, is a mention about verrucous carcinoma, which we now regard as being different from Buschke-Lowenstein lesion. And also we've got a statement about neuroendocrine neoplasms, which we feel is best dealt with in the neuroendocrine neoplasm dataset of the Royal College. So AIN or HCL. Essentially, this is an HPV-related lesion, and when you get an HPV infection, it will either clear or it will cause some kind of epithelial change, depending on whether you're dealing with HPV 16, 18, or one of the lower carcinogenicity HPV viruses. So the cellular manifestations will take in the form, or if it is a kind of low-grade carcinogenic virus, will be cholelithiasis and perhaps a bit of hyperkeratosis. And also there'll be some alteration in epithelial maturation, giving rise to this warty growth here. If it is integrated in the genome and leads to neoplasia, then you start getting what you see here on the right-hand side of the screen, this plastic focus, which eventually becomes cancer. This is a continuum, which traditionally we have referred to as AIN 2 and 3, depending on the thickness or amount of epithelium, which is so-called dysplastic, AIN 1, 2, and 3. And it progresses from one to the other, to look at it kind of simplistically. And once it invades the basal membrane, it is squamous cell carcinoma. Now, in our recommendation, we have moved away from this concept of AIN 1, 2, and 3, and we say it should be a two-tier system, LCIL and HCIL, but qualified in that in brackets you will still maintain your AIN 1 or AIN 1, 2, and 3 for HCIL. So what I'm going to do here is try to kind of go through the history of dysplasia and EIN to justify this change that we brought, the change that we have implemented. That is a change from a 3-tier system to a 2-tier system. Now, traditionally, we have considered cancer to have a precursor lesion, which we've called carcinoma in situ. This is a term which has been used for perhaps about 200 years and has been well recognized. The word dysplasia really it comes from the 1950s. Before that, the word was used, and it was probably Virchow who introduced this. And the term then was, in its pure form, was dys for abnormal and plasia for abnormal form. It applied to a variety of lesions, not necessarily neoplastic ones, including congenital lesions and some hematomatous lesions, and perhaps inflammatory lesions as well. But the term became hijacked really in the 1950s when cancer people kind of adopted this to mean the form of change in the epithelium, which was precancerous. And at that time, then the word dysplasia was kind of used fairly indiscriminately in relation to anogenital lesions. And people use words like mild, moderate, and severe dysplasia, atypical changes, and atypical hyperplasia, and so on. And it became time, therefore, to have a change. And that was in the 1960s, which kind of when the people were thinking about the cervical screening program. And the term CIN was introduced then by somebody called Richard, 1967, because he reasoned that we've got a continuum, and therefore we should have a term which will encompass severe to mild. And so eventually the term CIN 1, 2, and 3 was adopted, and in an equivalent being AIN 1, 2, and 3, by which time we got to the 1980s, and it was pushed fairly aggressively. And in the UK, everybody was using the terms CIN 1, 2, and 3, or AIN 1, 2, and 3 in relation to precancer in the anal region or the cervix when it comes to CIN. At the same time, in America, the Bethesda classification was being introduced, and that came out in 1988. And the feeling was that it should not be a 3-tier, it should be a 2-tier system. And the reasoning behind this, quite correctly, was that we were not dealing with a perfect continuum. We had at one end a lesion which is probably not cancerous at all, in which there is a cholelcytosis and a condyloma formation. And then at the other end, you've got something which is clearly neoplastic. So that was the thinking behind it. But that wasn't fully adopted, certainly in the UK, and for a variety of reasons. Then came the last project, which was really 2000, and 2012 was in fact when this was published. And the idea was that the group that made up the last project had the job of introducing terminology that had to be uniform, that everybody would understand, and where there would be consistency with cytology, and which also would reflect the underlying biological process. Now, to summarize the last document, I'll just give you the final recommendations in the last page of the document, in which they said there would be a 2-tier system, which we've qualified further with the letters IN at the end in brackets. And then they talk about this concept of superficially invasive lesions. And then they also made a few statements about the use of immunohistochemistry in relation to diagnosing HSIL and LSIL. Now, this then became adopted in various guidelines, just to mention WHO, CAP, College of American Pathologists, ESMO, which is the European guideline, and the American Cancer Society. All of them has adopted this concept of a 2-tier system. And sometimes they say, well, you need to put IN in brackets, but WHO actually omits that little bit. So that's where we are. In the end, the question that we ask ourselves is, does this really matter? Well, there's been a lot of discussion and controversy as to how we should treat and manage HSIL or AIN3 and 2 if you use the old terminology. And until a big trial was kind of published in 2022, the Anchor trial, where they followed up a large number, I think it was more than 4,000 patients with HSIL. So there were people with AIN3 and AIN2, and they followed this up not for very long. It was only for like 25 months, I think. And they found that there were 2 groups, one followed up and one treated by ablation. And if you ablate the lesion, then you cut the progression rate to cancer by 57%. So it made sense to completely excise or ablate the lesion if you've got a high-grade lesion in the anal canal. So that's probably the best evidence there is that treating these things makes a difference. And does it help us in terms of calling things AIN2, AIN3, and HCL? Well, it does actually support the idea that AIN2 and 3 must be together, because together they can be treated and you can get this kind of massive reduction in development of cancer. In terms of LCL, well, that trial didn't actually tell us anything about LCL, but we know from previous studies that low-grade lesion actually have a very low rate of progressing to neoplasia.
The clinical information is as shown here. I mean, interestingly, there's this history of UC, which probably isn't relevant. It might even be a red herring. But there was a plaque close to the anal verge. In fact, it's been called an anal lesion. Perhaps we should call it a perianal lesion, just to make things easier. Next slide, please. Right, so what you may not be able to see so well, but maybe on the left-hand side, there might be, if it was at higher power, there is background keratinizing squamous epithelium. So that supports this being from skin as opposed to anal canal proper, which, as you know, is lined by non-keratinizing squamous epithelium. And what we have here are two things. In the background, again, there might be a little hint of a subepithelial inflammatory infiltrate. Ideally, it would be even more lichenoid, but the action is occurring maybe more in the top left-hand panel, where the epithelium looks a bit thickened. Now, on the right-hand side, at higher power, you will not see the obvious sort of loss of maturation you'd expect to see in SIL or AIN if you want, but we can't get close enough. But the actual keratinocytes themselves are slightly on the plump side, nuclear-wise. And ideally, if we had some higher powered images, we might even see some dyskeratotic cells. And again, the two lower panels tend to emphasize more of that sort of possibly lichenoid sort of infiltrate. Next slide, please, Moorghen.
Yeah.
Is that it? Oh, yeah.
Yeah, well, there is some more. Yeah, it's just high magnification of what you already said. I mean, showing the base of the tibia a bit more, I suppose. There's possibly a hint of dyskeratosis on the right, but not my best shot. Not my best shot. And then we come here to the immunohistochemistry of the case.
Do you know, Moorghen, I'm going to let you comment on this, because I've read a paper that poo-poos the use of immunohistochemistry on this particular entity. But what it does show is that, okay, you might have some basal p53 positivity, but you certainly don't have that block-like positivity, which conventional AIN SIL shows, which is shown at the bottom. So the case is shown at the top left.
Yeah, sure. So the p16 staining here is non-block positivity, if you like, and that is kind of a feature which you often see in normal or even condylomatous change. But to call something AIN or AIN2 or 3 or HCL, then the positivity ought to be kind of so-called block-like, as you see in the bottom right-hand picture, where you've got cytoplasmic and nuclear positivity in a big chunk. It can be sometimes quite difficult, actually, because sometimes you get both. But you know, ideally, when you get both, you would like to think, well, all right, then where there's block positivity, it is in that area where there is your AIN, and where it is not kind of showing the positivity is the bit which is not dysplastic. But it can be a problem. It can be difficult to interpret. So we'll talk a bit more about the immuno in a minute. And then the 53, well, you should only get 1 or 2 cells. Perhaps that's not my best shot. You know, you should only get 1 or 2 cells staining with p53 in the basal epithelium, and it should be faint, kind of smooth, rather than strong and granular. Admittedly, here it's only a single row, but you know, ideally you want to get more than 1 row staining, and it ought to be kind of really hit you in the face. And then this is a feature of this particular condition. The other thing, because I took the picture, and so Newton is at a slight disadvantage here. So if we go back to the H&E, the kind of basal atypia which is described in that condition is, they say you get dysplasia, you get atypia, which is sometimes like a BCC, basaloid type with spindle-shaped atypical cells, but you can also get a form of dysplasia, which is, or atypia, which looks like that, where it is epithelioid, where the problem is that your nuclei are showing a kind of vacuolar change or vesicular change, and then the nucleoli really hits you, and they do here. But you've got to be very careful because, of course, that merges with what in fact may be a reactive phenomenon. And this is where the problem lies. So if you've got, that's where P53 comes and helps you. But there will be cases where your P53 will be negative, and we'll come to that in a minute. And there will be cases where the P53 will be positive, but then it's a bit of an overstain. So that's also a problem. When the P53 is negative, then we've got a bigger problem, because I've come across one or two of these cases, because in the anal kind of region, GI pathologists, I haven't seen many of these, but this is a more common lesion with regard to the gynae tract, and where people talk about lesions like VAM, vulval aberrant maturation, and DEVIL. DEVIL stands for disseminated exophytic vulval intraepithelial lesion, for example. And it's a problem is because what we've got here, in fact, in terms of the biology of the disease, is that this is a form of neoplasia, which is arising on the back of an inflammatory lesion. So it's inflammatory carcinogenesis, if you want to call it that way. And this is something which is getting more and more recognized. Of course, in advanced cancer, inflammation plays an important part in terms of driving this in terms of a stroma, which drives the cell to migrate and to infiltrate and invade. But actually, inflammation is also an initiator, and this is getting increasingly more recognized. So that when you've got a lesion in the anal canal, which is characterized by this kind of lichenoid inflammation, and you can't work out whether what you're dealing with lichen sclerosis, lichen planus, or something else, in a proportion of these, this will be a perineoplastic lesion. But the terms of DEVIL and VAD and so on has not been accepted, is not accepted yet in the anal canal, but it is well recognized, I believe, in the gynae tract, where it does cause difficulty there as well, I must say. It's not as straightforward as we say. But the point about this one, then once you kind of come to a point where you think that's what it is, that's a neoplastic lesion with these kind of features, then you're obliged to kind of treat it as if it is the anal equivalent of differentiated vulval intraepithelial neoplasia, where they consider it to be high grade VIN, and therefore high grade AIN. So you would need to kind of really ablate this. But although I must say, the evidence in the form of trial or whatever is not clear. Newton?
Yeah, I don't think you mentioned it, but were you going to mention the etiology of this differentiated squamous dysplasia, or call it what you want, dysin?
Well, it's right. Okay, yeah, it's an obvious point. Obviously, the thing is that, as I said to you, it's inflammatory carcinogenesis, and it is not HPV related, which is the reason why the P16 is negative. Yeah.
And so ideally, the background lichenoid type inflammation, be it sclerosis or rarely planus or something, that's same in the gynae tract.
Yeah, correct.
Apparently, it's been reported in the oral cavity as well. But are we going to talk more about it, Moorghen? Because I just wanted to add, from a personal point of view, it is really hard to diagnose. I struggle.
I think that's correct. I mean, we all struggle at that, and I worry about this because are we overcalling or undercalling? And it's absolutely impossible. And if you've got a lichenoid kind of dermatosis like this, at what point is this simply a lichenoid type keratosis of no neoplastic significance? At what point does it become neoplastic? Are we really going to rely on five brown cells? That worries me. I think probably we will have the same problem. Yes, but anyway,
so
just to go back.
Thank you. I think it is. I think it's now more or less complete. Your presentation, is that correct? And I would like to transition to the question and answer type. And we got one very specific question. If you leave this image here, this slide, what is the interpretation of P53 in this case? Is it wild type or is it aberrant? Perhaps you could comment on the antibody that's being used. Is it just expression or is it a mutation? What is your answer?
Well, it's aberrant. It's aberrant non-wild type. I mean, the wild type one would be a faint staining, and there's some faint staining here as well. Actually, there's some wild type present as well within that epithelium.
But the antibody, to be specific, the antibody itself only detects wild type.
I think there's more than one antibody that works. The DO7 is the one that most people use, I think, and that seems to work with us. But in my experience with p53, you've got to be very, very careful, because in different labs, it shows different sensitivity. And you can get everything to become positive, and it looks like as if it's kind of aberrant.
So going back to the question,
type. Yes.
going back to the question of the first questioning. So what's the, is it wild type or aberrant?
Mutant.
It's mutant.
Aberrant mutant. Yes.
Yes. Okay. So the next question that we have in the audience here is, do you perform the IHC on all the lichenoid lesions?
Right. The answer is no, but you've got to be careful. Okay. If you've got something which looks like lichen planus, and you can convince yourself that there's no basal atypia, then that's what it is. If you've got something which looks like lichen sclerosis, and there is no basal atypia, then that's what it is. If you've got something which looks like lichen planus, but it's hypertrophic lichen planus, then, I mean, this is purely personal opinion now, then you would look again, because hypertrophic lichen planus, which has got a lot of hyperkeratosis and parakeratosis, doesn't occur typically in the anal canal. It's a lower limb lesion. And then you would lower your threshold now when you're trying to assess for atypia.
Okay. Did that answer your question? Just to the person who asked the question. And we move on to the next question. It says, can we call it heterogeneous type mutant?
I don't know what kind of mutant it is, to be honest.
Is it heterozygous, perhaps?
Possibly.
Perhaps. Could you? I'm just asking the person who asked the question. Can you rephrase your question, perhaps, please? And whilst you're doing this, I have a question regarding the P16. So probably along the lines with the P53. How robust is it? Is there a prescribed antibody? Is there a multitude of antibody? Are they kind of pre-diluted tests which are standardized, like HER2, etc.? How reliable is it? How robust? And how much can you actually rely on it?
No, I don't think it's like HER2. I think there are several antibodies on the market, and if it's like most antibodies, if your control works, then it works all right. So we're not quantifying really here. But having said that, don't underestimate the problem, because it can be very difficult to decide whether something is positive and negative.
And related to this, there's a further question from the audience. Do we do P16 on all anal cancers?
Right. Okay. So that actually is mentioned in the guidelines. So for invasive tumors, we do, because the P16 positive ones have a better prognosis. Now, in regard to dysplastic lesions, that is L-SIL or H-SIL, to stick to the last guidelines, the kind of dogma coming from them is it's not done routinely, but it is useful in differentiating between the high-grade lesions and the low-grade lesions. And you may want to do that for that reason when you need to.
Okay, thank you.
Yes.
Regarding the P53 expression, there is one comment in the chat in our comment section, question and answer, saying, I think P53 here is showing basal overexpression with a mutant pattern of staining. That I think is, and if I'm remember correctly, the antibody itself detects wild-type protein, but the overexpression is through the accumulation of pathological protein, which is co-detected with the antibody. Is that correct?
Yes, correct. That's how I understand it.
So
and when you get this overexpression, and also the quality and high magnification of the stain is more granular, and its accumulation as a result of the mutation. Yes.
Just a quick one.
Guys, can I come in, Sebastian? Sorry to interrupt you.
Yeah.
This is not to contradict anyone in particular, but just to give you a slightly different perspective.
Yes.
I'm possibly a bit old school or a bit of a heretic, but I'm not the biggest fan of using immuno in these contexts. With regards to P53, as you rightly say, we're just picking up protein. We're not picking up mutant protein. So it accumulates if you've got whatever mutations, you might stabilize the protein or stop its degradation. But we're talking about slightly qualitative assessments. And again, maybe I'm a heretic or I'm too not good enough to make those assessments, but I'm always slightly nervous about making these sort of assessments based on P53 staining. The same way as I'm slightly hesitant to do it for Barrett's as well. You can't comment whether it's heterogeneous type mutant, and you certainly can't comment on whether it's heterozygous type mutant on immunohistochemistry. So you couldn't call it on that. And the same goes to P16, but that's just my point of view. So I can't answer questions about antibodies because I don't rely so much on either to make these diagnoses.
And
Yeah, I
finally,
agree with
although
that. I think that's right. The other thing about 53 is that you can have an aberrant expression or you can have absent expression. So, and both indicating kind of suggesting neoplasia, and that makes it even more difficult. So in the end, you are diagnosing it based on this kind of basal atypia, which is difficult because how do you separate that from reactive changes? So you should not, I agree with the entire, we should not rely on just P53 to make your diagnosis. You rely on the atypia, definitely. And with P16, and P16, remember, is basically a tumor suppressor. It's a surrogate marker only of HPV. It doesn't tell you it's HPV infection. In fact, one of the stats was going to kind of explain that, but that's by the by.
For gynae differentiated VIN, the CK17 immunoreactivity has been found to be useful. How about the anal ones?
I don't know. I don't know about the anal ones. I never used it. I don't know. I haven't seen any papers where people have looked at it. I couldn't answer the question. But from what I remember, for these for the it may well be actually because they tend to pick out the kind of the basaloid cells more, the CK17, but whether it will actually be discriminatory enough in saying this is dysplastic because it's positive and that was negative, I doubt it. Yeah.
So there's another question. Someone who also put a hyperlink in, which I put into our chat. So if that was a vulval biopsy, I would probably call that a wild-type pattern of staining and say the most recent name for the HPV-independent lesions in the vulva is VIN. So that's for future reference. Okay, very good. Whilst everyone is looking at it, just a comment from my personal professional experience with P53. Yeah. We are using antibodies for a lot of tests in CNS tumors. So for the audience, I'm a neuropathologist and I practice neuropathology oncology. And I never used P53. We don't even have it in our repertoire in the department because of the very same concerns that Newton just had explained, because it detects a wild-type protein, which may or may not, the staining of which may or may not increase if there's a mutation, which may lead to accumulation. So we do not use it as a surrogate marker for mutation, just to clarify. So there's probably some parallel here. And so has anyone else a question from the audience? Whilst we give the audience time to type in further questions, just
Sebastian,
generic. Yes,
sorry to interrupt. I'm very glad to hear you say that, Sebastian. I did detect a little smile when I was saying what I was saying, so that's probably why. The only time you can be certain something's wrong with P53 is the null phenotype, perhaps. But in my experience, especially when you use it for Barrett's, it's something which you can diagnose with your eyes anyway. So I'm equally skeptical as to the utility of P53. But if people do look at that figure, there's an image which talks about the so-called wild-type basal picture, which shows a few basally positive cells. And then there's a picture which shows the abnormal basal picture, which has a lot more positive cells. But again, being a skeptic and maybe a bit of a doubting Thomas, I would pose to you, how many dotted decorated nuclei do you need to have to distinguish between the so-called wild type and the basal? And that's when again becomes a bit gray and a bit sort of murky. So the bottom line is, from my point of view, just be slightly cautious about using immunohistochemistry to try and make these black and white diagnoses.
So we're back to the. I think you're right. Actually, I think we should go back to the days of Virchow. Displays as equal to abnormal form, and you go back to your cells. I think that's safest, really.
So whilst we're waiting for possible additional questions from the audience. Just about generic question from a kind of implementation point of view. Do you see any difficulties in the implementation of these guidelines into practice in all pathology departments generally in the UK or worldwide? What difficulties might there be?
Yeah, Newton, do you want to answer that, or shall I have a go?
Which particular guidelines, Sebastian?
These ones here, these
one.
specific ones.
About
anal cancer. Yeah,
No,
the anal
no.
cancer
the ones in
guidelines.
general.
Yeah,
The anal cancer guidelines. Is there any aspects in this new version of the guidelines that is a change from the previous guideline that requires changes in the delivery within pathology departments?
My first reaction would be no. I think probably the most controversial point would be, as was touched upon by one of the delegates, was whether we should be staining all cancers for P16. I think that's controversial. I do know that some hospitals are more keen, and as usual, this tends to be driven by oncologists. Certainly in Bristol, they don't ask for P16 to be tested on all anal cancers. I know in the head and neck, P16 predicts for a better prognostic cancer, which is more likely to respond to chemo-rad. But we're not at that stage, I feel, universally with the anal canal cancers. So perhaps in the future, yes. But at the moment, I don't feel it's a national requirement. So again, maybe I'm a bit of a lazy heretic, but I'm not pushing for universal testing as yet. And there's certainly no NICE guidance that says thou shalt test all anal cancers with P16.
Yeah.
Okay. There's one more comment. May I say thank you to the panel for the critical assessment of P53 in the use of squamous dysplasia, because this is implemented currently only on the basis of some papers proposing possible use. So in a way, the discussion was quite timely and quite to the point. There's another question that just popped in. Is there a role of HPV in situ hybridization testing? Does anyone do this? Is it relevant here?
Yeah, well, not in the anal canal, but I think it's quite important. Head and neck cancer, but there's no evidence that it makes it, it should be used for anal cancer. Agree, Newton?
Yeah, not so much for anal cancer. I mean, the only time I do use it, and perhaps it's at the risk of wasting my departmental's sort of immuno funds, is if there's something which has been sent as a fibroepithelial polyp or something similar, and I think, this could be viral wart, because the difference, if it was just an FEP which is excised, the patient would have no follow-up. Whereas if it was a viral wart, then the patient should be followed up and surveyed because of the higher risk of cell developing. Most cases of FEP, I'd like to think I can distinguish from a viral wart, but there's the occasional rare case where I think, could it be viral wart? And in those situations, I must admit, I do ask for HPV high and low risk in situ. I accept that not every single variant of HPV is covered by this in situ testing, but if it does turn out to be positive, then I would obviously veer towards a diagnosis of viral wart and then the patient needing surveillance. So that's the only time I tend to use it in anal sort of lesions.
Yeah, makes sense.
Okay, thank you very much. There are no further questions from the audience. Anything that we have received yet? In that case, we thank the two presenters for this fantastic presentation, for the lively discussion. We thank the audience for putting in all these questions. There's a final question coming on. Are there any specific clinical guidelines for follow-up on anal SAIL?
In terms of follow-up, I think the best I think there is guidance here from the College of American Pathologists and also from AGS and also from ESMO, I believe. And the guidance is based on the results of that anchor trial published in 2022, which says that for HSIL you need ablation or some kind of complete removal.
And another question just popped in. Is condyloma equivalent to AIN1?
It is not equivalent to AIN1. AIN1, which, strictly speaking, we should not be using at the moment. is in the neoplastic pathway. It's a low-grade lesion, but the problem is that it's quite difficult to decide when something is AI, one is not, and one is normal. So it's going to lump together, but it is not. One is along the carcinogenic pathway, and the other one is not. But it's quite difficult morphologically to separate it sometimes.
Okay, thank you very much. So then we have finished with the question and answer. Just to everyone, please be aware that the recording of today's webinar, including the question and answer, will be made available soon on the Royal College website, and it will be placed as a resource for our members to use to support them when implementing these guidelines. So if any of your colleagues weren't able to join us today, please let them know and they can watch it from our website. So the other point that I would like to make you aware of, the professional guidelines team will be sending around a short feedback survey, and it would be really great to hear what you thought of today's webinar, how interactive and useful you found it. Thank you again, Moorghen and Newton, for sharing your expertise, and thanks all for participating in today's webinar. And please check our webinar webpage and stay tuned for new coming webinars related to this program. Have a good day. Bye.